So the first topic will be given by Dr. Sunaina Bhatt, who is an associate professor in Father Mullah Medical College, Mangalore, and she'll be dealing with the topic evaluation of a case of concomitant squint.
Hello everyone, I'm Dr. Sunaina Bhatt. I'm practicing in Mangalore. So this session is going to be about evaluation of squint, and I'm going to be talking about evaluation of concomitant squint. I would like to thank the office bearers of Karnataka Ophthalmic Society for giving me this opportunity to speak to you all. Yes. So what exactly is a concomitant squint? So it is a non-paralytic kind of squint. Basically, you're dealing with a deviation which remains same in all the positions of gaze, and there is no limitation of extraocular movements. What technically is the cause? So basically, the development of binocular single vision occurs anytime starting from around 3 to 6 months, which goes on for around 5 to 6 years. So any obstacle in the development of binocular vision at this time. So it may be a sensory cause like refractory errors or any media opacities. There may be a central deficiency of fusion or cortical deficiencies as you see in CVI, or there may be a motor cause in the form of malformed orbits or extraocular muscles. So as it is when you're dealing with any case, the history and the initial assessment is very important. So you may want to ask the parents about the age of onset, whether it is constant or whether it is intermittent, whether it is always seen in one eye or it is seen in both the eyes, whether there is a difference between how it is when the child looks at a distance or near. So a FAT scan, that is a familial album tomography, is very useful. So nowadays it's very easy. Most of them have all the photos of the child on their mobile phone itself. So it's very easy to look at various periods of the life of the child, say 6 months, 1 year, like that, to get a fair idea about how the squint is progressing and the laterality. The birth history, whether there has been a stormy post-birth history like an ICU admission, there may be a family history of deviation, and always ask for associated comorbidities and if the child is on any medication. So as I said, your assessment starts as soon as the child walks into your chamber. Look for any nystagmus, look for any associated syndromic features, look for any anomalies in the palpebral fissure, which may be actually giving you the appearance of a pseudostrabismus. So the core of assessment of concomitant squint is the motor assessment or the cover tests. So the cover tests are basically of 3 types. There's a direct cover test, there is a cover uncover test, and there's an alternate cover test. So once you have determined the type of squint, you're going to measure the amount of squint, and the other 3 tests mentioned here will help you to do that. So cover test is only as good as how well it is done. So there are certain prerequisites for a cover test. The presence of an adequate fixation target is definitely a must. So in all the children, in all the patients who are visually able, that is the visual acuity is good, making them read the Snellen's chart and a near chart would be the best way to perform the cover test. We must always perform the test in up gaze and down gaze. Look for the deviation for near and for distance. So if the patient is wearing glasses, you need to do a measurement with and without the glasses. Traditionally, the palm of the hand or occluder is sufficient. If you're suspecting any dissociated vertical deviations, the Spielman translucent occluder is very useful. And in case of exotropias, where you're suspecting a divergence insufficiency, cover test after prolonged cover, that is a patch test, is very useful. So what is the cover test? So when you do a cover test, so basically there is a fixating eye and a squinting eye. So the direct cover test is nothing but you're going to cover the fixating eye and look for how the squinting eye behaves. So this basically tells you about the sensory adaptation of the squinting eye. If it's a well alternating squint, the squinting eye will immediately come and take up fixation. Whereas if there is a dense amblyopia, that doesn't happen. Now, what is the cover uncover test? So basically here you are covering the fixating eye, and when you remove the cover, you observe how the eye deviates, how the eye behaves. So in case there has been an esophoria, under the cover, the eye would have gone into a convergent position and a refixation movement occurs towards the midline, which gives you a diagnosis of esophoria. Now, an alternate cover test is nothing but you're breaking the fusion between the two eyes. So it is used to diagnose a latent squint. So you quickly move the cover from the one eye to the other, breaking the fusion and hence unmasking a latent squint. So now we go on to the measurement. Frischberg's test is a very like a crude way of measuring the squint. So basically you're looking at the corneal reflex. So as is shown here, around 1 mm deviation indicates around 15 diopters of squint, and a large deviation of around 4 mm indicates around 60 diopters. Now, a more adequate or a more accurate measurement would be with prisms, that is a prism bar cover test. So basically you're using the alternate cover test along with prisms. So you place increasing strength of prisms in front of the squinting eye and do the alternate cover test and look for the moment when the refixation movement stops. So the advantage of a prism bar cover test is it measures the entire squint. So there may be a manifest part and a latent part. So you're measuring both in a prism bar cover test. Now, the prerequisite for prism bar cover test is that the child should be having good vision. Now, what do you do in case of patients with amblyopia or sensory squint? So we can do a Krimsky's test where you place increasing strength of prisms in front of the squinting eye and look for centration of the corneal reflex. The modified Krimsky's test is when the prism is placed in front of the normal eye. Now, this is done in patients with corneal opacity and where the corneal reflex may not be very easy to identify. So what does a cover test basically tell you? It tells you whether there is a latent squint or a manifest squint. It tells you the type of deviation. It tells you the sensory status, whether the squint is alternating well or there is amblyopia or eccentric fixation. It will also tell you, you can also measure the deviation, the primary and the secondary deviation. The next thing you're going to look for is limitation of movements. So the limbus test. So basically how far from the limbus, you can see how far away from the midline you can see the limbus, tells you the limitation of movement. And in case of oblique overactions, the angle it makes with the horizontal line. So especially in cases of esotropia, you may need to measure the vergences for which near point of convergence, for which we use the near point ruler or the RAF guide. This is the normal range of vergences that you can actually measure, and it may be important in some cases of exotropia or esotropia. In rare cases, there may be other tests that you want to add to your examination. One such test is the AC by A ratio, where basically it is measuring the range of accommodation which happens with convergence. So there are two methods to do this. One is the heterophoria method and the gradient method. Now, the 4% base out test is a test which is used to diagnose suppression scotoma. This is done especially in a patient where you're suspecting micropropia. So when you place the prism in front of the eye, the refixation movement occurs because of shift in the gaze. However, in a patient with suppression scotoma, that refixation movement doesn't happen. So once you're done with the motor assessment, you need to know what is the sensory impact of the squint that you're dealing with. So basically, it can be measured in two types of methods. One is the Diplopia principle and one is the hapnoscopic principle. So in Diplopia principle, basically, you use one physical location which is split into two perceptions. And in hapnoscopic, there is two physical locations which the patient is supposed to match. Yeah, so these are some of the common examples, the Worth 4-dot test and the Pagolini striated glasses, which gives you a fair idea about the sensory status of the eyes. The next important thing to measure is the stereopsis. So there are qualitative tests like the Lang's two pencil test, or quantitative tests like the Titmus fly test, random dot test. So to summarize the whole thing, first is to establish the type and the amount of squint. Then you're going to determine the underlying cause of the squint and the sensory impact of the strabismus, and which finally gives you a fair idea about the management. Thank you very much. I hope it was useful.
Thank you, Dr. Sunaina, for the wonderful talk on evaluation of a case of concomitant squint.
Actually, evaluation of squint can seem daunting, especially to the first year PGs or initially. But a systematic evaluation, as explained above with a detailed history and a repeated practice with all your covered tests and other prism tests, will give you the necessary confidence to make a diagnosis and treat a case of squint.
The next speaker is Dr. Chinmay, who's an associate professor from Minto Ophthalmic Hospital. She'll be covering the topic on evaluation of a case of paralytic squint and localization of cranial nerve lesion.
Hello, everyone. Greetings from KOS. And at the outset, I thank Dr. Ilan, Dr. Sunil, and Professor Dr. Nagaraju for this opportunity. I'll be speaking on the evaluation of paralytic squint. As my previous speakers have already highlighted upon the evaluation of the concomitant squint, my talk will be limited to the specific tests that we will have to be doing in paralytic squint. So in the history and symptoms, the important thing is about double vision or anomalous head posture. So that is the main characteristic feature of the paralytic squint. We have to observe these symptoms and the patient's complaints, and we have to check the ocular motility, the cover test, the measurement of the angle of deviation, fusional reserves, diplopia chart, and the Hess charting have to be done. Head posture could be either a face turn like this or a head tilt like this. Look for the amount of deviation. It could be a large deviation like this as a right esotropia, or sometimes the deviation will be smaller, particularly when the deviation is a vertical squint. It will be very difficult to pick up the deviation if you are not very careful enough. Observe the 9 gaze positions for any abnormalities of the movements. So that has to be documented in the cardinal positions of gaze, and it has to be documented like this, wherein we will write the individual muscles and the grade of limitation. It is not only enough that you write limitation of abduction, adduction, but then you have to write because of the lateral rectus muscle and grade 1, 2, 3, 4, how much is the grade also has to be mentioned. If in this case, it would be right LR limitation grade 4 and left MR overaction grade 1. Like that you have to mention. Sometimes the limitation of movements is not very obvious. Like in this case, as you can see here, it's only a grade 2, grade 3 limitation, grade 2 to grade 3 limitation, but the overaction is very prominent. So both the underaction and the overaction have to be mentioned. Sometimes inferior oblique muscles have overactions, and that has to be documented as well. Along with the eye movement limitation, we sometimes have palpebral fissure changes in aberrant innervations. In this case of third nerve palsy, we have the inverse Duane sign wherein the patient has lid retraction in adduction. So that has to be documented. Also, we have to note the presence of any other cranial nerve palsy, as in this child with 6th nerve palsy. There is also an associated 7th nerve palsy. So that also has to be done. All cranial nerves have to be examined whenever there is one cranial nerve palsy. Cover tests have been covered earlier. In this patient with right 6th nerve palsy, I want to show you the importance of noting primary and secondary deviation. Primary deviation is the deviation seen in the paretic eye, which is very small, and secondary deviation is the deviation which is seen in the normal eye when forcibly making the paretic eye, that is the right eye, fixate. So because of Herring's law, the antagonist, that is the medial rectus muscle here, and also the contralateral antagonist receive excess innervation, and so you get a larger deviation in the normal eye than seen in the paretic eye. So secondary deviation is always higher than the primary deviation in paralytic squints. Park's 3-step test, beichovsky's head tilt test are done mainly to rule out a superior oblique palsy. And you have to note that this is only for an isolated single cyclovertical muscle. The Parkes 3-step holds good only for that, if only a single muscle is involved. So right hypertropia increasing in left gaze, increasing in right head tilt will lead to a diagnosis of a right superior oblique palsy. Measurements of deviation have to be done in all the 9 gaze positions. So note that here the patient who has a 10 prism diopters in primary position, it is decreasing on the right side and increasing on the left levo version. So this incompetency, that is the hallmark of incompetent squint. So the deviation is not constant in all these 9 gaze position. So it will be lower in one gaze and higher in another gaze. So all that has to be documented. Moving on to the sensory test, here we have to use some sort of dissociation. So in the Wurzburg test, we use a red and green glass. By convention, the red glass is on the right side and the green is on the left side. And the patient is asked to view a target of 4 circles. And a normal person will see a target like this, and the lower circle may be either red or green depending on the dominancy. In competent squint, they can see it as suppression. In incompetent squint or the paralytic squint, the patients will give a response of 5 dots, that is diplopia, and this may be crossed or uncrossed. When the patient sees red on the right and green on the left, 5, it becomes a uncrossed diplopia. And when the green is seen on the left side, because the patient is wearing green light on the right, but seeing the images on the left side, so that becomes a crossed diplopia. Similarly, we can use a MADDOX rod test to dissociate the 2 eyes. Here, the patient is asked to look through a MADDOX rod, which is nothing but a cylindrical lenses here, which converts the point source of light into a streak of light. So the patient is made to wear the MADDOX rod on the one side, and he will be seeing at the pen torch on the left. So a normal person will see the overlap, the pen torch here and the line right on that. But if the response is like this, it becomes an uncrossed diplopia. When the MADDOX is on the right side, it becomes a crossed diplopia when like this. So MADDOX rod is another useful test, which it's very useful because it's there right on your trial set. You don't have to search for anything. You don't need a red and green glass. The MADDOX rod is there in your trial set, and you can use it and see whether it is crossed or uncrossed diplopia. And then we have the diplopia charting. So here this patient is asked to just show with her finger. So in the clinic, immediately you can ask. So on this double vision, it's becoming single on the left gaze. It is increasing in primary position. And then moving on to the right side, it is increasing in size. So the same thing is now charted using the streak retinoscope, red and green pencils and paper, and red and green glasses. Here you are going to stand behind the patient and then project the light and ask her how much is the difference between the 2 red and green. First you will tell which side is the red. If the red is on the right, it is an uncrossed diplopia. Red is on the left, it becomes crossed diplopia. First, once you noted the image difference, now you ask in primary position what is the size. In the right side, it is increasing. Note how much is the difference. Here, how much, and moving on to the left side, it is collapsing. So the same thing is done in all the 9 positions of gaze and documented like this. So here you can see that it is single on the left side, but it is increasing on the right side. The amount is increasing. 1 centimeter separation is becoming 3 centimeters. So that is charted like that, and it will give rise to a diagnosis of right 6th nerve palsy. Similarly, you can chart for other cranial nerves, even the cyclovertical muscles also. Hess charting works on the principle of projection. So here you can see that this patient is made to touch the finger using the normal eye, where she will touch it very, very accurately. Okay, but when we ask her to touch the finger same way with the paretic eye, that is the right eye, notice that she is not able to touch it but moves past the target. So this is past pointing, and this is the same principle that is used in doing the Hess chart. This is the chart that is used, and this is the electric Hess screen. Here you can see there is a central circle, central dot here, and there are 9 points around that which forms the inner square, and the outer square which are done by the 16 targets. And this is the control. So the patient wears a red and green glass, and the charting eye is always the eye with the green glass. Okay, so we have to reverse the color. So once, now this is the left eye that is charted, and now here it is the right eye that is charted. And as we press on the buttons, the targets on the electric Hess chart get illuminated, and simultaneously the patient is given a green laser pointer, and they will be pointing on that, and you will be charting on the chart. So let us see how the procedure is done. So we will explain to the patient how it is done. So here, this is the control, and with this we are going to press the buttons, and here you can see on the target the light is getting illuminated. So the patient is given the green pointer, and that pointer has to be put on these targets. So here we are charting the right eye because the green glass is on the right side, and the light that we are going to, whichever, first we will chart the central circle. So she is able to accurately point. So there is no double vision on this side. And here also she is able to put it exactly on that point. So this is how the Hess charting is done. So this is the normal side. And then the other side is done, wherein the person will point it past the target. Okay, so that is how it is done. See, now this patient is taking time to do it on that, and this is how it is charted. So you can see that once it is charted, see here, this is the normal side, and here I have still not connected these dots. You can see for the left side lateral rectus, she should have pointed it here, but it is pointed here. So that means that it is a left lateral rectus paresis. So I hope you are clear with evaluating a patient with the paralytic squint, and I hope all this double vision, charting, everything has become clear. And all these tests have to be done in conjunction with the other tests that have been told in evaluation of a concomitant squint. So everything will remain the same, plus these tests of double vision will be added. Okay. So thank you very much for your patience here.
Thank you, Chinmay ma'am, for an extensive talk on paralytical squint and helping us to understand more about squint and also the practical aspects. What do we face while examining a case of squint?
The most important thing, especially PGs, when we come across paralytic squint cases in OPD, is that with all the examination which has been explained to you now, you don't miss, and you need to find or localize the lesion. You don't miss out an underlying lesion. Like sometimes the paralytic squint might be the presenting feature of an underlying life-threatening lesion like an aneurysm. And you might be the first doctor that the patient is encountering. So it is important that you don't miss in these cases the necessary imaging, whatever is necessary, and referrals which is needed. Thank you.
The next talk will be by Dr. Soumya Ramani, who is the Associate Professor from MS Ramaiah Medical College. She'll be covering the topic on evaluation of a case of restrictive strabismus.
Hello, one and all. I'm going to be speaking to you about restrictive strabismus. At the outset, I'd like to thank the organizers, including Dr. Ellen Kumaran and Dr. Nagraju, for giving me this wonderful opportunity to speak about evaluation of restrictive strabismus. So when you have a case of restrictive strabismus, what is the pertinent history that you've got to take? So as is the case with any disease, and particularly strabismus, you need to ask the onset of strabismus, whether or not there is any functional or psychosocial difficulty, and if there is, what is the degree of that difficulty, and importantly, the expectations of the patient. Also, you ask about onset of diplopia or ocular misalignment. You look through the family album and figure out whether there is any familial association. Certain diseases, such as in some cases Duane's, can have a familial association. And of course, you ask for ocular or orbitofacial trauma, because trauma in itself can be an important cause of restrictive strabismus. Thyroid orbitopathy, again, a very important piece of information that you need to glean from the patient. and previous neurological or neurosurgical problems. When it comes to examination, a lot of our restrictive strabismus have typical head postures, and such as a face turn or a chin lift. So you need to figure out whether there is a head posture. Facial asymmetry is an important piece of examination that you need to see. Lid palpebral fissure anomalies. Like you can see in this picture, we have a patient with a medial ectropion, and there is he had an a restricted superior gaze. So you sort of know that there must have been some trauma over there causing this problem. And of course, exophthalmometry, it tells you regarding the thyroid status. And as is the case with most strabismus, you need to figure out the cover test. And if there is a good fixation movement, you know that there is unlikely to be a paretic strabismus, and a restriction is probably a cause. And you need to check for the strabismus in all gaze positions, because in some strabismus, you could have upshoots and downshoots, which you need to be on the lookout for. So what are the salient features? So restriction is not commensurate with deviation in primary position. Okay, so suppose you have an EXO, you would expect an abduction deficit. But if there is an abduction deficit and an exo, then it's probably a restrictive strabismus. Good saccades are one of the salient features, and they can be globe retraction and, of course, gold standard positive force duction test. Associated features, you look for lid malpositioning, palpebral fissure narrowing, exophthalmos or enophthalmos, like in the case of an orbital flow fracture, and conjunctival scarring. So some concepts that you need to keep in mind are, one thing is fixation duress. Okay, so because there is some restrictive component that is disallowing the eye from fixating, there is a lot of impulse to that particular muscle, and hence the secondary deviation is usually more than primary deviation in restrictive strabismus. And there's this concept of a leash and a reverse leash effect. So for example, in this muscle, because of restriction there, it's not allowing an lateral movement, and a reverse leash causing a disallowing of a medial movement as well. So we mentioned that a force duction test is a gold standard. It's very, very important. In any strabismus, before surgery, during surgery, after surgery, you do a force duction test. So in a force duction test, the globe is moved passively. The patient gaze direction is similar to the direction of force applied by the examiner, because you want to see whether by passive movement, the eye is moving completely. So if it is not moving, then most probably there is a restrictive component. Right? So when you're doing it for the recti, you need to proptose the globe, while when you're doing it for an oblique, you need to retropulse the globe. So your force duction test can be helpful in grading the amount of restriction. So a grade from 0 to -5. 0 indicates that there is 100% movement, -1, 75% of movement remaining, -2, 50% of movement, -3, 25%, -4, no movement beyond the midline, while -5 indicates that the eye cannot even reach the midline. Okay, so this can be very useful in grading your force duction test. So you must remember, restrictive strabismus, you would think is only mechanical, but it could be innervational as well, as is the case in Duane's. So what are the restrictive syndromes? So you can have a congenital as well as acquired. There are a plethora of syndromes, but we've just listed a few. So congenital, you have Brown's, Duane's, Mobius, fibrosis syndrome, strabismus fixus, where in acquired, you have blowout fractures of the orbit, thyroid eye disease, and post-retinal detachment. So let's look at it, in this way. So first is limitation of elevation of one eye. So if you have a restricted force duction test, you can consider Brown's, fibrosis of inferior rectus, endocrine myopathy, or blowout fracture. So look at this case. You have a right hypotropia, and you have a limitation of elevation and adduction. So this is a case of Brown's syndrome. So in Brown's, you have limited elevation and adduction. If it is mild, there is no vertical deviation or a downshoot. Moderate, there is a downshoot and adduction. And in severe, there is hypotropia in primary position and a downshoot and adduction, as was shown in the picture. And when you do a force duction testing, there's restriction to passive elevation and adduction. Next is if you have a depression, limitation of depression in one eye, and there is a restricted passive duction, then it's most probably a blowout fracture. So we all know what a blowout fracture is. It is basically fracture of the floor of the orbit. So you could have restriction of both up gaze and down gaze. Remember the leash and reverse leash effect? That comes into play over here. And an important finding is in infraorbital anesthesia, and of course, restricted elevation typically. And if the muscle is severely entrapped, you could even have nausea and bradycardia as a part of an ocular cardiac reflex. Next is limitation of abduction. So if you have restricted force duction, it could be a chronic sixth nerve palsy or a Duane's. So what is a Duane's retraction syndrome? So basically there could be a congenital absence of the sixth nerve nucleus in varying degrees in a sense. So in type 1, you have abduction, which is more limited than adduction. Type 2, adduction is more limited than abduction, while type 3, there is both limitation of abduction and adduction. Having said all this, there are various other types which will not be going to the details of. So again, to reiterate, in type 1, there is abduction limitation, type 2, adduction limitation, and type 3, both are limited. So you may or may not have a strabismus in primary position, but even if it is there, it could be an ESO or an EXO. There are eyelid fissure changes and globe retraction because of co-contraction, and you could have a compensatory head posture and anomalous vertical movements, like you can see an upshoot in adduction can be seen. The next thing, you could have a limitation of adduction. So if you have restricted passive adductions, it could be a Duane's or it could be an endocrine orbitopathy. So what are the features in thyroid eye disease? Something which is very typical is the differential IOP testing. So IOP is different in primary and up gaze, and usually more than 6 millimeters of mercury is considered significant. A slit lamp examination is important to figure out other changes typical of thyroid eye disease. Optic nerve evaluation is important, of course, to find out whether there is any compressive optic neuropathy. And a Hurdle exophthalmometry sort of hits the nail in the head to tell you whether it is a thyroid eye disease or not. What are the specific signs? This is something that all of us know and have heard repeatedly. Chemosis and or caruncular edema and restrictive strabismus, of course. Eyelid retraction with lateral flare, proptosis, compressive optic neuropathy, and fluctuating eyelid edema and or erythema. And on radiology, you will have evidence of rectus or levator muscle involvement, and most commonly the inferior rectus is involved. If you have a limitation of vertical gaze in both eyes, right, and you have a positive force duction test, it could still be an endocrine myopathy, or it could be a congenital fibrosis of extraocular muscles. As you can see, you have really tiny, tight muscles in the first picture of the radiology as against a normal patient. If you have general limitation of ocular motility and you have a positive force duction test, it could be endocrine myopathy as well as CPEO or fibrosis of extraocular muscles. What happens if you have painful restriction of ocular motility, right? It could be myositis. It can be an acquired Brown's. So in congenital Brown's, we've already discussed it. An acquired Brown's can actually be painful. And if you have generalized restriction, like a total ophthalmoplegia, as you can see in this case with proptosis, it's probably a Tolosa-Hunt syndrome. So prism and cover test measurements in all positions of gaze, for distance, for near, are very, very important. And incompetence is a consistent feature in your restrictive strabismus. So just to recapitulate, if you have an abduction deficit, you probably should consider Duane's or a thyroid orbitopathy. Adduction deficit, third nerve palsy, tight lateral rectus syndrome. Elevation deficit, orbital flow fracture, thyroid orbitopathy, Brown syndrome. Depression deficit, thyroid orbitopathy, and inferior rectus palsy. So in summary, in a restrictive strabismus is not in line with a movement deficit. Saccades are good, but there can be an abrupt stop of the saccades. FDT or force duction testing is the gold standard test. And you need to look for associated ocular and systemic features to pinpoint which syndrome we're looking at. So thank you for this wonderful opportunity. Keep calm and keep learning. Thank you.
Thank you, Soumya ma'am, for giving a wonderful talk on restrictive strabismus. It is very helpful on all the tips that you gave for us on a day-to-day squint practice and examination.
I think one of the cases that the PGs will commonly be encountering in OPDs every day is for trauma cases. Many a times there'll be cases that you see at bedside references, polytrauma cases with other departments. So in those patients, sometimes because of the associated inflammations and also maybe the patient is not very cooperative, you have to be careful while examining. And depending on the trauma, you have to keep a high degree of suspicion and look for any presence of the fractures or restrictive strabismus. Thank you.
The next topic is anomalies of pupil, which will be covered by Dr. Sumita Muthu, who is a consultant in Department of Pediatric Ophthalmology and Strabismus, Narayan Netralaya, Bangalore.
A very good morning, everyone. Today I shall be discussing the anomalies of pupil under the following headings: anatomy, pupil examination, normal pupillary reflex, abnormal pupillary reaction, and abnormally small pupil or meiosis, and abnormally large pupil or mydriasis. So before we move on to the conditions, you must know a little on the anatomy. So dilator pupillae muscles are supplied by the sympathetic nerves, whereas the sphincter pupillae is supplied by the parasympathetic. So this is the dilator, dilator pupillae muscles. They're radially oriented, and the sphincter pupillae, which is around the pupil, which is circularly oriented. So parasympathetic and the sympathetic supply here. So the parasympathetic supply is as follows. So the afferent goes from the optic nerve through the optic tract and then to the pretectal nucleus here. So this is in the midbrain. So then from the pretectal nucleus, it goes to the Edinger-Westphal nucleus, and then thereon through the oculomotor nerve and through the ciliary ganglion, it supplies the sphincter pupillae through the short ciliary nerves. So the dilator pupillae muscles, or the pupillary dilatation reflex, is through the sympathetic supply. So this comes from the sympathetic chain, and it goes to the superior cervical sympathetic ganglion and then to the plexus, which is around the carotid artery or the carotid plexus, and then through the long ciliary nerves, it supplies the dilator pupillae muscles. So coming to pupil examinations, what do you look for when you normally examine the pupil? One, you look for the size of the pupil, whether both the pupils are equal in size, and then you look for the shape of the pupil, which is usually round and regular. It can be irregular in a number of ophthalmic conditions and a very few neurological conditions as well. And you also look for the light response and the accommodative response. So how do we, of course, the size and shape is something that you can examine, or you may also look for subtle changes on a slit lamp examination. So coming to the pupil examination, so before you examine for the light or the accommodative response, it's very important that the room is dark, the lighting conditions are dark. And you must also give a distant target. So it may be a Snellen's chart, or you may just ask the patient to look outside a window. And then when you shine a torch, suddenly you look for the pupillary constriction. So a distant target, very important. And then you suddenly shine a torch. This can be from the temporal side or from the nasal side. And then you look for the pupillary constriction, which is usually brisk to light. So next, now again, when we look for the accommodative or the near reflex, you ask the patient to again look at a distant target, as I previously said, and then you bring in a near target suddenly in front of the patient. So when the patient suddenly looks at the near target, of course, there's again a constriction of the pupil, and this is the part of the near reflex. So the near reflex is usually less as compared to the light reflex. That is, the constriction that occurs to a near reflex is usually less as compared to that of a light reflex. So coming to the anomalies of the pupil, so you have the afferent defects. So you have the afferent defects, which can be the problem with optic nerve and the tract lesions. And this is called a relative afferent pupillary defect if it is only in one eye, or it can be a bilateral afferent pupillary defect as well. The efferent defects, okay, these result in a condition called anisocoria or unequally sized pupils. And this can be a problem with the parasympathetic supply, or it can be a problem with the sympathetic supply. Then finally, we have a condition called the light near dissociation. So I just mentioned that the light reflex is always better than the near reflex. So there are conditions where the near reflex is better than the light reflex. That is, the reaction to accommodation is much better. So these are in tonic pupil, Argyll-Robertson pupil, dorsal midbrain syndrome, aberrant third nerve, regeneration, and various other conditions. This can also be seen in case of myotonic dystrophy. So coming to how do we examine for an afferent pupillary defect? So we perform something called a swinging flashlight test. So you must remember that when you do the swinging flashlight test, you must switch between the right eye and the left eye, and do not spend too much time on a particular eye. If you think the right eye is abnormal, it's not that you spend too much time on the right eye, because you also know that normally there's something called a physiological hippus. That is, there is constriction for some amount of time, and then there can be small, variations, that is small dilatation and then followed by a constriction. So this you may again mistake for an afferent pupillary defect. So spend equal amount of time on both the eyes and then perform a direct light reflex before you check for the afferent pupillary defect, because you must know to what extent each pupil is constricting even otherwise. So again, for an afferent pupillary defect, ask the patient to look at a distant target and then throw in a torchlight. So you will be looking at the pupil that you, normally examine with the torchlight. But what you must know is that there is equal amount of constriction of the other pupil as well, because the fibers eventually in the light reflex, the fibers are equally distributed. So they're bilaterally represented, and the fibers, the efferent pathway, the neurons are equally distributed to the right and the left pupil. Okay, so there's equal amount of constriction of the right as well as the left pupil, irrespective of which light you throw the light on. So this is what happens look at what happens when you shine the light through the right eye. There is equal amount of pupillary constriction of both the eyes, whereas when you shine the light on the left eye, you see that there is a relative dilatation. It's not that there is a dilatation, it just means that the amount of constriction of the pupil which is happening when you throw in light on the left eye is less as compared to the right eye, and therefore you experience a dilatation. I mean, you actually notice a dilatation when you switch from the right eye to left eye. Otherwise, if you shine the light only on the left eye, just the way you look for the light reflex, you will find that there is a small amount of constriction, but this amount of constriction in the left eye is less as compared to the right eye, and therefore it is a relative afferent pupillary defect in the left eye. So coming to the grading of RAPD, it is grade 1 if there is a weak initial constriction followed by a greater redilatation. Grade 2 if there is a stall in a moment followed by definitive dilatation. Grade 3 if there is an immediate pupillary dilatation. Grade 4 if there is a pupillary dilatation during prolonged illumination of the good eye. And grade 5 there's an immediate pupillary dilatation and no sign of constriction at all. So coming to anisocoria. So what is, before we move on to what is pathological anisocoria, what is physiological anisocoria? So when there is a difference in the pupillary size between the two eyes, and which is usually less than about a millimeter in size, and this difference in size is sort of maintained in dim and dark light conditions. That is, when you examine both the pupils in dim light in a dark room, as well as when you examine the pupils in a bright light condition, the anisocoria is similar. Whereas pathological anisocoria is something that changes in dark and dim light conditions, and depending upon whether it changes in the dim light conditions or dark light or the bright light conditions, you can diagnose what is the problem. So what happens in dim light is there is pupillary dilatation. Okay, so if there is anisocoria which is exaggerated in dim light conditions, it obviously means there is a problem with the dilator pupillae or the sympathetic pathway. If the anisocoria increases in bright light conditions, obviously it means, so in bright light there is pupillary constriction which occurs. So obviously there is a problem with the parasympathetic supply or the sphincter pupillae muscle. So coming to various conditions which cause meiosis or an abnormally constricted pupil, they are Horner syndrome, opiate overdose, pharmacologically constricted pupil like the use of pilocarpine eye drops, or in case of uveitis where there's usually posterior synechiae, or there can also be an abnormally constricted pupil in such conditions even without synechiae. So on the right you can see the various conditions which can cause Horner syndrome, the various levels at which they're affected. It can be a central lesion, preganglionic, postganglionic, or after the internal carotid artery bifurcation. I already showed you the pathway for the parasympathetic supply. So the various tests to diagnose are the hydroxyamphetamine test, so which is usually positive in preganglionic lesions and negative in postganglionic lesions. So coming to mydriasis. So mydriasis occurs in something called the stonic pupil, okay, where the near response again is more than light response. Is also a light near dissociation. It also occurs in third nerve palsy, a pharmacologically dilated pupil, just the way you use dilating drops, a sphincter pupillary damage, which can occur, with trauma. So coming to the pilocarpine test for mydriasis, this is very important to diagnose the cause for a dilated pupil. So the most commonly used test is, of course, the 0.125% pilocarpine. And so once you see that there is a unilaterally dilated pupil, and then you apply a 0.125%, if there is a dramatic constriction within, say, 10 to 15 minutes, so you can diagnose the Addis tonic pupil. So this is because of the relative hypersensitivity of the receptors, and therefore there's an immediate constriction. So if it only constricts with a 2%, then it's a third nerve palsy. If there is no constriction at all, then it is a pharmacologically dilated pupil. Third nerve palsy again does not require a test with 2% pilocarpine. There are, of course, other signs which helps you suspect a third nerve palsy. So let us look at this table. It of course seems complex, but let me take you through each of these conditions. First, if you come across an anisocoria, then you check whether it is more in dim light or more in bright light conditions. So I already explained that, say it is more in the dim light condition. So this means that there is a problem with the dilator pupillae, or there is a problem with the sympathetic supply. So they can also, so there is a problem with the dilator pupillae. So now when you use a 10% cocaine, okay, you can do the 10% cocaine test. And if the anisocoria is more than 1 millimeter following this, then it is a Horner syndrome. Then again, you do a hydroxyamphetamine test to detect the level of lesion, that is whether it is a preganglionic or a postganglionic lesion. Okay. Next, coming to the other condition where you see a anisocoria which is greater in dim light, is a functional or a mechanical restriction to dilatation. This can happen if there is syncope, if there is uveitis, or if the patient is on meiotic drops like pilocarpine. So this is a structural or a pharmacological meiosis. So bilaterally dilated pupil, of course, can be seen in neurological conditions, can be seen in midbrain lesions, etc. Then, for example, in Perinaud syndrome, you can find bilaterally dilated pupils. So coming to condition where anisocoria is greater in dim light conditions. So I mean in bright light conditions. So this occurs because of a problem with the pupillary constriction, or because of a problem with the parasympathetic supply. So yeah, so if you apply a 1% pilocarpine, I mean 0.125% pilocarpine, and there is a pupillary constriction, then that is suggestive of Addis tonic pupil. So in Addis tonic pupil, you also see some something called a segmental iris palsy, wherein when you look for the pupillary constriction on a slit lamp, this is especially obvious on a slit lamp, you see that only parts of it constrict, and so it looks like there's a vermiform movement of the iris. This is because only part of this pupillary sphincter constricts, whereas other parts do not. Okay, and of course, you can use a 1% pilocarpine, etc., to diagnose the third nerve palsy, but that doesn't again require this test. You can, detect it with the restriction or the limitation of movements and ptosis. These are other conditions which can be associated with it. So again, when you look at the slit lamp, if there is damage to the pupillary sphincter, if there are sphincter tears, then of course you know that there is iris damage. Iris damage can also occur in other conditions like siderosis. Okay, so this is a summary of anisocoria and the various conditions which can cause anisocoria. So with this, I conclude my presentation. I thank KOS for all the opportunities, and I thank my PG Apeksha who helped me with the presentation. Thank you.
Thank you, Sumita ma'am, for giving an excellent talk on pupil. As pupil examination is one of the most important examination we as ophthalmologists do, so that because it will point out to a lot of underlying conditions which will give us a clue that this could be the cause, and we can do a better evaluation based on the pupillary reactions.